Good evening, friends. Welcome to this Tuesday evening sessions from Yashoda Group of Hospitals and ICCM Hyderabad chapter. We try to bring some interesting topic of interest for all of us. And for the last few years, as an intensivist, I've been seeing one of the lethal poison which I encountered is paraquat. Unfortunately, because of its low cost, and very useful in agriculture fields. This has been very popular in many of the rural agriculture belts and has been a common poison by these farmers and agriculture and also the other people who actually go and buy this as one of the easiestly available poison. Interesting part is many of these family members come to us and say the person has consumed a very little amount of paraquat or the poison, and
Yes.
they say he vomited, he spelt out, or he just expelled it, and they assume this will not be of any importance because it is just hardly a 10 ml or 20 ml, and they
Exactly.
are not unaware that this 10-20 ml can be lethal in this kind of paraquat poisoning. Unfortunately, we come across hundreds of cases in the last, I think if we count in the last 4 years, we have in all our units, we have hundreds of cases. Very few, maybe 10 to 20% of these cases, fortunately escape it. And many of them are because of a very low dose which they took or they tried only to take it. And because of its corrosiveness, they exhaled it or they expelled it, or the quantity is too low. But most of the times when they go into a multiple organ failures, then it became lethal and we get into a stage where there is a point of no return. And this has been a very common scenario which we come across. But what has been suggested, if you look at the world of literature, including the latest guidelines from UpToDate or any toxicology textbook, if somebody has consumed a very heavy lethal dose and crossed a 6 to 8 hours of time before he reaching to the hospital, then the lethality is so much that it is almost a death sentence. So all your efforts are not may not be going to make any difference. And sometimes the literature also suggests, some authors recommend a palliative kind of phenomenon, not to go very aggressive, don't ventilate them, don't give them support if the family is going to be dry out. So contrary to that, there are many studies which suggest this paraquat poisoning can be treated by many combination of immunomodulation drugs, immunosuppressive drugs in the form of high dose of steroids, cyclophosphamides, in a combination of many antioxidants in the form of vitamin C, or in combination of N-acetylcysteine and all. The reason they all suggest this is the mechanism of action of paraquat. This paraquat enters into the cells and create a redox cycle, creating a superoxides which actually exhaust your NADPH. And this happens over a days to week. Sometimes it takes 5 days to 1 week time for all these organ functions to fail. You may see a patient looking very normal for the initial 3 to 5 days, but after the 5 days, you see the patient losing one after the other organ. So this is one of the complex poisoning which we come across. And unfortunately, at this point of time, this is freely available in the market, and we are losing many young lives to it. So it happens to us that we came across Dharinendra, who is a senior consultant heading the department in Ramesh hospitals in Vijayawada. He happens to discuss that they have a series of these paraquat cases where they have dealt in a different way using hemoperfusion, which many of our centers do, and they are trying to keep a track of it. And for that reason, and he has been a part of a faculty where he has delivered a good number of lectures on that. So it is fortunate for us that he will be here to give us insight into it. Welcome, Dr. Dharanendra, on board.
Thank you so much, sir, for that introduction, sir.
Thank you. We will we'll come to you. We welcome
Yes, sir.
Dr. Vivek Gupta. Sir, can you switch on the camera, sir? So Dr. Vivek Gupta is heading the unit in Ludhiana, DMC, Dayanand Medical College, and been a part of both ECMO director and a person who has a great vast experience in the field of this poisoning, including the paraquat, where they have to try to bridge many or do hemoperfusion in many cases. So we felt he will be a expert for us, guiding how we could have been done in a different way in these cases, even though we know it is a lethal. So we welcome you on board, Dr. Vivek Gupta sir.
So thank you, Dr. Venkat, for inviting me for this discussion, because we all know that paraquat is lethal, but an early hours are always beneficial. So this will guide us that how we should approach these patients and what are the options we have. Thank you. Thank you for inviting.
Yeah, over to you, Dr. Dharanindra.
Thanks for the kind introduction, Dr. Kola sir, and Dr. Vivek Gupta sir. Thanks for being here, sir. I'll just share my screen.
You can go to full screen or close it and open again. I think sometimes.
Oh, yes, sir.
Next one.
Okay.
Yes.
So our journey with Paraquat started way back in 2020. So when I first started my work here at Ramesh Hospital, initially this Western Krishna district, the Krishna district which is on the highway from Vijayawada to Hyderabad, we call it the West Krishna. So this West Krishna was having lot of usage of paraquat as a herbicide and as a gaddi mundu, they call it in Telugu. So this is the dry part of the Krishna district. So we were getting lot of cases, and the main issue was they were coming in late. They were coming in late, and uniformly we lost the first few cases. Therein, when we went to the particular places and found out with the local IMA body and spoke with the local doctors, many a time, just like Dr. Kola sir told, they think it is unfatal. The poison portion for paraquat is just a mouthful. Just a mouthful. I have one case right now in Ramesh Hospital, Ongole. The family gives history that he has taken in something and he is just split out, or he was dilute. It was a dilute paraquat. They have mixed water in it, 3/4 of it, and he has consumed little bit and split out. That was the history that was given. And today, urine Dithionite test is positive, and the hypoxia started setting in. So, as Dr. Kola sir, told, it is the awareness among the people that is not there, about the toxicity. Sometimes they just simply do it to scare other people. Our initial case, index case, a 16-year-old person has consumed paraquat and organophosphate just to scare. He doesn't know that it was so toxic. So many consume it benignly because it's uniformly available across the country. It is cheap, it is not regulated, there is no government regulation on availability. Anyone can just walk into the store and buy paraquat. So just like Dr. Kola was saying, randomized control trial evidence and all, especially for agriculture poisonings like paraquat are very limited. So majority of the trials we are getting in from the Asia. Majority of the trials are from the Asia, from Iran, and from China. And the EXTRIP, the Extracorporeal Toxin Removal Society has also formulated some guidelines for that. So before we discuss about the core topic, what we did with our case series, we're going to just talk the basic thing about extracorporeal toxin removal. So just like for other toxins, the problem with paraquat is it is a contact. It causes mucosal damage, it causes tissue damage. We cannot readily use the conventional decontamination methods for paraquat easily. For example, we cannot conveniently give lavage, rice lavage. If it's a dilute solution, maybe it's controversial to put a nasogastric tube as well, but if it is we just check the oral mucosal ulcerations. If there is no oral mucosal ulcerations or palatal ulcerations, we try to put a Ryle's tube in the early phase. If it comes late, it's of no use. If it comes late beyond 4 hours, it's of no use. Any external decontamination, conventional decontamination measures. And extracorporeal toxin removal, again, is the mainstay of decontamination in paraquat. So before I go into the paraquat, we are going to start the basics of extracorporeal toxin removal. So this is the extracorporeal toxin removal decision algorithm. So for any poisons in which we don't have an effective antidote, so extracorporeal toxin removal is indicated. Also, when the poison is lethal without an antidote, and it also causes multi-organ failure, especially organ injury, vital organ injury, kidneys, lungs, liver. When all these vital organs are involved, it is prudent that we stop, we start the ECTR, we stop the conventional methods, and we have to start the ECTR at the earliest available time. So if the patient, especially for poisons like agricultural poisons like paraquat, we don't have an antidote, they are lethal, they affect all the organs, all the vital organs, and they can be hemoperfused, they can be removed. So extracorporeal therapy is the main modality of management, especially in paraquat. So this is the decision algorithm for any poisons. If you want to decide whether to give an extracorporeal therapy for any particular poison, this is one chart that you should go through. So in this chart, it's simple that when is ECTR not indicated, when is ECTR indicated. So this chart we have downloaded from XTRIP guidelines. We can readily download it. So ECTR is required in compounds like paraquat and aluminum phosphide and other compounds in which we don't have a clear-cut effective antidote. So that basically the ECTR, whether you can do it or not, it depends upon the molecular weight, volume of distribution, protein and tissue binding, and endogenous clearance of a compound. So it all depends upon these factors. So the molecular weight decides whether a poison is dialysable or not. Okay, so high flux dialysis filters can remove molecules up to 15,000 kilodaltons, and high cutoff and middle cutoff membranes can clear molecular weight substance up till 50,000 kilodaltons. So the main thing, this single slide will tell you for which molecular weight, which modality is good, and for depending on the protein binding of the toxin, which modality is good. So if the toxins are highly protein bound, hemoperfusion and therapeutic plasma exchange are the only options. So in paraquat poisoning, we are basically using the hemoperfusion modality along with hemodialysis modality. There are many studies which have studied about combination of usage of hemodialysis and hemoperfusion. Again, it can be easily done. It can be again easily done. So volume of distribution is very important for anyone who is dealing with extracorporeal toxin removals. Only when the volume of distribution is limited, you can get the poison out of the body, and your extracorporeal toxin removal will be good. Again, the compound's hydrophilicity, if the compound is having smaller VD and is more hydrophilic, you can remove it easily with the extracorporeal toxin removals. So plasma protein binding is very important. Toxins which are highly plasma protein bound, you cannot get them out with hemoperfusion. And endogenous clearance, again, if the patient is having good renal and hepatic functions, many of the toxins can be metabolized and they can be cleared with endogenous mechanisms. But the issue with paraquat is you cannot leave it for endogenous clearance to happen. It is highly toxin bound. It destroys the cell. It causes hepatocellular necrosis. It causes type 1, type 2 pneumocyte injury, and it causes acute kidney injury. So the only way is to get it out. Again, the mode of removal of the toxin is important. So hemoperfusion acts by the mechanism of absorption. Adsorption is a surface phenomenon. So all your hemoperfusion cartridges that we're using, just like the HA230, they have a synthetic resin they use the surface area of the synthetic resin for hemoabsorption. So again, many studies combine hemodialysis with hemoabsorption for extracorporeal toxin removal, and for that matter, paraquat removal as well. So the function of hemodialysis in combining hemodialysis and hemoperfusion in paraquat is, if the patient has a renal dysfunction that has already set in, it will also help to clear the uremia acid, and it will also correct the acid-base electrolyte abnormalities also. So hemoperfusion is a contact phenomenon. High surface area of resins and high surface area of resins will help to help the toxin bind to the hemoperfusion granules and cartridge granules, and it's a van der Waals forces phenomenon. That is why they make sure that when you design this perfusion cartridge, we utilize the largest surface area of the resin. So charcoal was a broad spectrum absorption agent, but what happened with charcoal agents was there were a lot of problems like hemolysis and all other vascular problems. So what happened was the cartridges have evolved from 1950s to the current date, and now we are having polystyrene coated toxins, polystyrene coated granules. So the advantage of hemoperfusion over hemodialysis has lessened the advent of other high flux dialysis membranes and all that. So currently for paraquat poisoning, hemoperfusion is the gold standard. So this is the typical hemoperfusion cartridge of HA230 cartridge that we use. So you can see on the screen that it is having so many small resin granules. So what essentially happens is that the toxin essentially binds to the small resin granules when you pass the blood volume into the cartridge. Okay, so the issue over here is it requires systemic anticoagulation. When we start the hemoperfusion, we have to give 5,000 units unfractioned heparin bolus, and we have to keep anticoagulating. Anticoagulation is very much required, and that is one issue. What happens is when we start anticoagulating, sometimes these patients tend to bleed from the airway. So many a times what happens is they have mucosal corrosions on the mouth, on the vocal cords and all that. And many a times once we start hemoperfusion, they may end up requiring airway management also. So you have to be prepared for all those factors. You have to be prepared for all those factors. And the paradox with paraquat poisoning is we have to set the FiO2 to the lowest point. Oxygenation, causes further free radical injury to the lungs. In paraquat, we used to keep the FiO2 0.3. Sometimes if the patient is maintaining saturation and if his lungs are intact, we go for the lowest FiO2 possible, lowest FiO2 possible to keep the saturation 90, 92. That's it. In a young patient, even 88 is good as well. So that is the key here. Once you start the hemoperfusion, these are the practical problems that we faced. And the other thing, other problems that we faced are, bleeding from the site of the cannulation. You have to go for, single prick hemodialysis catheter insertion. If you're comfortable with the right femoral, it's well and good, because you'll just do the hemoperfusion for 3 to 4 days, and after, if the patient is urine diethynite negative, you can just remove the cartridge, you can just remove the dialysis catheter. So you can always go for the right femoral, single prick, you can go ultrasound guided. And we always go for the right femoral because we don't want to waste time for anything else. We want to keep the door to hemoperfusion time to the minimum, So urine diethynate test, when the patient comes to the emergency room with paraquat, suspected paraquat poisoning, alleged paraquat poisoning, immediately we do the urine diethynate test. Okay, so when urine diethynate is positive, it is confirmative of paraquat poisoning. It is again very easy to do. It's a point of care test. You can repeat it again and again. After first hemoperfusion, you can do the urine diethynate test again. If it is positive, go for the second hemoperfusion. And after the second, you again do the urine diethynate. If it is positive, you go for the third. So like that, each hemoperfusion session lasts for up to 4 hours. So urine diethynate test is again very easy to do. I'll describe it at the end of the session. So this is the urine dithionite positive on the left side of the screen. That is the urine dithionite positive. As the patient is coming to the ER, we just, when you put the Folase, we take the first urine sample, send it to send it to the lab. We get the urine dithionite positive, and immediately we take the right femoral vein cannulation. We start the hemoperfusion, and after 1 or 2 hemoperfusions, you can see the pictures on the right side. So that is the hemoperfusion, that is the urine dithionate negative. So after the hemoperfusion, you get the urine dithionate negative. And so it is so remarkable. You can see whether you have achieved the therapy. You can, you use it as a point of care solution to decide when to stop the hemoperfusion and when to stop the hemoperfusion. So this was one of our first cases. He was a 16-year-old kid. He has consumed paraquat with organocarbamate. Co-ingestion. He has done a co-ingestion, and immediately we started the hemoperfusion. And after the hemoperfusion, his urine dithionate became less negative. What happened was, after the hemoperfusion, he started respiratory distress and he went into the cholinergic syndrome, and we had to intubate him. And we were also concerned how much of paraquat is left inside, so we had to ventilate him with the lowest FiO2 possible. So he came out on the 6th to 7th day of ventilation. So we were able to save this person and we were able to discharge him. The only thing that happened very efficiently in this person was the doctor in the periphery has referred to a center capable of hemoperfusion at the earliest. So many a times what happens is, if you don't receive the patient within 4 hours or 5 to 6 hours, it becomes a very tedious task. It becomes a very tedious task. Your organ failures don't resolve. They set in and they are here to stay. So if you start the hemoperfusion at the earliest time, the number of tissue damage, the multi-organ failure, you can avoid. So what happened in this case was, we got the patient real fast from the periphery. Again, we combine our hemodialysis with hemoabsorption. You can see in this picture that we have both the hemoperfusion catheter on the top, hemoperfusion catheter on the left top corner, and we have the hemodialysis catheter, hemodialysis filter down. So we combine both of them. So it also helps in removing the uremic toxins when the AKI sets in, and also it increases the life of the cartridge. I mean, what happens is, many a times the cartridge gets saturated easily. If you want to run a 4-hour hemoabsorption therapy, if you don't have the hemodialysis catheter, the hemodialysis filter, the hemoperfusion cartridge runs out in 1.5 to 2.5 hours. So if you want the hemoperfusion cartridge to be active and doing its job for the 4-hour session, if you combine it with the hemodialysis cartridge, it stays on. So all the agricultural toxins which are hemoperfusible or hemodialysable, it is the intermittent hemodialysis. So intermittent hemodialysis is the gold standard. There is very little role of CRRT except in aluminophosphide poisoning. So we want to get the dialysate out we want to get the poison toxin out as soon as possible. That is why we are using intermittent hemodialysis. So, of course, for cases like aluminum phosphide poisoning, Vivek sir must have done lots of work on aluminum phosphide. So we use CRRT for those kind of patients. So it is very good when you're having an unstable patient, hemodynamically unstable patient. And of course, the main issue with CRRT in the periphery is the cost involved with the therapy. So again, therapeutic plasma exchange and plasmapheresis we usually do for some toxins like mushroom toxin, which are extremely rare. So plasmapheresis is most useful for mushroom poisoning. So to summarize, I'll tell you that hemoperfusion is the ideal mode of toxin removal for agricultural toxins like paraquat and some other poisons like some other drug poisons like valproic acid, carbamazepine. CRRT is good for lithium. And hemodialysis is good for toxic alcohol, salicylates, and lithium as well. So the key here I want to convey is extracorporeal toxin removal should be done in the golden hour. There is golden hour for stroke, there is golden hour for MI, and there is golden hour for paraquat as well. So the golden hour is the 4 to 8 hour window. I'll just present my data. So this is the HA230 filter that we have been using for all our 38, 40 cases that we have used. HA230 filter is the filter we have used. So this is our data, our center data. You can see that ingestion to door time when it's more than more than 5 hours, more than 6 hours, uniformly we had mortality. And what all the cases that we were able to salvage came to us early. And these cases came to us early because we were able to go for a critical care contact program. We speak to those doctors, we go to those doctors, we tell them that paraquat you have to refer early in a humble manner, and we have done that in the last 3 years, and that is why we are getting the referrals early. So when we delayed more than 8 hours, immediately we have mortality. Many a times what happens is these patients are coming from slow socioeconomic background. They have money just for 2 days of ICU stay and hemoperfusion therapy. After the hemoperfusion therapy and urine diethionate comes negative, they ask for shift to government hospital, GGH. So many a times they go DAMA, but we follow them up and we say, we follow them up with our contacts, and they turn up well, So that is what hemoperfusion in time saves multi-organ failure, saves morbidity and mortality as well. So, and the other cases, few extraordinary cases, I'll tell you, we had combination of paraquat with organophosphate co-injections, and those cases also, if they present early, we are able to salvage. And the other thing is, we have seen in our cases, some cases have with high positivity of paraquat. You don't need to do the urine diethionate test. As soon as you put the Foley's catheter inside, you get blue urine. So that high positive cases, those are literally non-salvageable, those kind of cases. I mean, we attempted hemoperfusion in those cases, but we had mortality within less than 24 hours.
Yeah.
So this is the conventional resin bond interaction, which is based on our HA230 380 filters. So we predominantly use the HA230. So I'd like to conclude.
Yeah. Thank you, Dharanindra, for that interesting information. I could see around 40% of your patient had a fortunate to actually survive instead of that lethal poisoning. And as you said, the time was the major constraint there, where it was a challenge. So we will come back to you later. First of all, we will invite Dr. Vivek Gupta, sir. So you have been seeing a lot of toxicology cases, as pointed out, not just paraquat, but many others. But today's discussion is more to paraquat. So what is your take, sir? What is your mortality there? How many cases you see? What are the limitations?
Yeah, that wonderful question, actually, Dr. Venkat, because as a tertiary care center and as Dr. Dhanindra said rightly, that referrals when it is late and patient is reaching beyond 6 or 7 hours, then there is sure shot mortality if patient is not in the milder category. If they have taken the moderate to large amount, they have taken one mouthful, and those patients, they usually do not do well. So uh, we have used extracorporeal therapies in almost 15, 16 cases. And 4 we were able to discharge whom we had done the hemoperfusion. The only good thing was that they reached early, around 6, 7 hours they had reached to us, and we initiated with the hemoperfusion. Same filters we were using, this HA230, and they did well. Other patients, they did not do well, though few were recovering, but they finally took the DAMA and they went home. So for those 3, 4 patients, we cannot say that what was their follow-up or whether they survived it or not. And ECMO we have done in 2 cases. One patient, the family was initially willing for the transplant, but later, after a month, they decided that they will not go for the transplant, probably some family issues or something. and other because the family was very influential, so they took for transplant, but unfortunately he did not get a lung, and they had to withdraw it after almost 3 months of time. So these are the few cases which I have. But as rightly said, that it is the time which is very, very important, that if we are coming early. If the patient is coming to your emergency department and you are initiating this hemoperfusion very early. Though in those patients who are not affordable, we do use hemodialysis or CRRT in those patients, but results are usually not very good in those patients. The only thing I would like to add that if the paraquat concentration is high, then only hemoperfusion is useful. If it is a low concentration, then possibly it has not much impact on this toxin. That's the thing. Rest all he has covered very nicely.
So coming to, we will discuss each point in an elaborative way, sir. Coming back to the initial resuscitation measures in any toxicology. It happens many times to us that we don't know the poison, unknown poison. I don't know how many of you, both of you, come across. It happens to me that many young patients came to me after 1 week having multiple organ failures, and we started working up for the etiology of multi-organ failure in a young girl or a young boy with autoimmune diseases and all. Later on, we find a tongue coated with a ulcer margins, and we do an endoscopy and realize that this looks like a paraquat. So this is not unusual. So this has also been a common phenomenon. Because of the social stigma, many families keep that, or even the patient himself keep it as a hidden, not expressing. So it is not unusual, and even sometimes the patient may think that amount of 10 ml is not the cause for all this, or he or she is suffering with some disease because of which he's getting all this. So the coming to the first point, sir, we will discuss about the timeline, but before that, as even Dharanindra pointed out, if a patient reaches to a hospital early, even it is a corrosive chemical burn we see after a couple of days or after a few hours. But initially, I happen to see many of my patients, when I examine the oral cavity, it may look healthy, it may just look an erythema.
Exactly.
Not look the ulceration what we see after a couple of days or 4 days after, which actually have a very coated white color ulcerated tongue. So rightly pointed out, initially if somebody reaches, so the maybe gastric lavage in an early part, or maybe giving an activated charcoal, aspirating back whatever content is left behind, is still a phenomenon, unlike what we do for many corrosive acids and alkalis, because many of the times the aerogastric structures are not chemically damaged, because it is not like a direct contact induced corrosiveness which happens with acids and alkali, but it is because of a cellular mechanism which actually exhausts your oxidative scavenging system, that leading to cell death, leading to ulceration.
Okay.
So that is the reason we get that buffer of doing a Ryle's tube aspirate, if at all, if some paraquat is left behind, and giving an activated charcoal. And the timeline again remains the same, as early as possible, but between 2 to 4 hours, maximum up to maybe 12 hours, not beyond that, we don't have any benefit. Now, the second point which actually has been discussed is timeline for a hemoperfusion. The earlier is the better, we all understand, but 4 hours, which actually Dharanindra spoke about, the 4 hours probably is a cut-off time where you have seen a clear benefit versus that. But so many times it is not practically possible that, as Dharanindra, in spite of his all outreach programs, could show me that about only 50% or 60% of his patients could reach to the hospital within that timeline of 4 hours. And majority of the times, many of us don't receive this patient before 4 hours. So now the other question remained is, till what time, both of you, even we know there is a gray area that you don't get the benefit which you're looking for, but still you offer a hemoperfusion in many of your patients. Vivek sir, first to you.
So we usually, as you rightly said, and it was pointed out that it's the time which matters, and most of these patients, being a tertiary care center, they initially go to the first hospital. They are able to do initial management, or they are referring, and in all these things, usually it takes more than 4 or 5 hours. So usually we initiate hemoperfusion up to 8 hours. But after that, we usually do not start. If we get a patients before 4 hours, it is wonderful. And those patients who have survived, actually, they were in the range of 4 to 6 hours range. But usually we try to start up to 8 hours. But after 8 hours, we do not offer them for the human population.
What is your practice, Dharanendra?
Sir, first thing is in our data set, about our 50 patients, many a times what happened, despite everything, they come after 8 hours, after 12 hours. What happens is we come to an ethical challenge actually. What happens is he'll be urine Dithionite positive and he's in front of me and he has come after 8 hours. He's a young person. Usually all these kind of poisonings are happening in young people. So we have an ethical dilemma. I explained the family that I don't know how much benefit I will offer by this therapy, but they are like, sir, do something. You cannot watch a person die. Arey, kuch to karo yaar. They're like that. They become desperate. They're like, doctor, I will not say anything to you. Whatever happens, you try. If it happens, it's our luck. If it doesn't happen, it is his kismat. And they give us a leeway. So I do
social
it, sir.
ethical request. But do you actually, there is an interesting slide which you showed Dithionite test in all your urine samples. And do you take that as a marker whether to do or not?
Sir, what happens is urine Dithionite test here is a confirmatory feature of paraquat poisoning.
Is to
Usually,
include
what
or
happens is
exclude?
if it is positive, we do it, irrespective the patient is clinically stable also, we do it. And if it is negative, we repeat it, sir. I mean, especially when the history of the consumption is very short, they bring the container with them. If it is negative in the first test, we repeat it again, and it will come positive many a times, sir.
So you wanted to explain how you do a Dithionite test in the last of your slide.
Yes, sir. So urine Dithionite test, actually we take the sodium nitroprusside. So what we do is basically to alkalize the urine. So once we alkalize the urine, we add sodium Dithionite to it. So when we add sodium Dithionite to it, what happens is the urine color, usually if it is straw colored initially, it turns into various shades of blue. It is a semi-quantitative test. So it turns into various shades of blue. Higher the concentration of paraquat, darker the color of the urine Dithionite.
Okay. It will
Okay,
be
and if it is a diquat, then it will turn to blue.
yeah, diquat, it will turn to blue.
It will
So
turn to
diquat
blue.
is almost like another paraquat is of the same group, which actually acts in the similar fashion of mechanism of action. So you do your lab does regularly, sir, Dr. Vivek Gupta, sir?
Not really. Our lab doesn't do.
So, Dr. Dharanindra, is it a regular lab or you customize it for your ICU?
No, sir, it is actually very simple. We need two reagents, sir. One is uh, we need sodium nitroprusside, and the other thing is we need this dinitrate test. Two reagents we get readily available. So we do it at the point of care. When we receive the patient in the emergency room, we straight ahead do it, sir.
No,
One alkalizing agent, and one Dithionite crystal. That's it.
No, I'm asking the two reagents you bring or your biochemistry lab does it. You bring and you do like what we do 20 minutes whole blood clotting time, or your lab does it.
Lab does it, sir. Lab does it. We send it to the lab.
Lab, okay. So there are some interesting questions. So hemoperfusion, hemoadsorption therapy, charcoal hemoadsorption or perfusion cartridges may not be available in all places, and they are not ready to go to a center. So what are the other alternative we can attempt?
Sir, the majority of the studies coming from Iran and China, they say that a combination of hemoabsorption and hemoperfusion is good, but hemodialysis alone is not beneficial, sir, because you'll not get the compound out of the blood. You're just getting the toxins out, and it is acting like a dialysis for a renal replacement therapy. That's it. So you need to do hemoperfusion, sir. Many studies coming from China have combined hemoperfusion with conventional hemodialysis. They have combined with CRRT. They combined with many other modalities, but without the hemoperfusion, you're not getting the compound out of the body, sir. I checked on many of the trials.
Okay.
It is not effective.
So the way I think it gets absorbed from the gut into the circulation, and from the circulation it gets distributed into the different body parts through a highly perfused organs, to start with your renal system, your liver, then your lung, your myocardium, and luckily not to the brain, because of blood-brain barrier it doesn't cross the brain, but the rest all the perfused organs get this toxin adequately by 6 hours time. The initial 6 hours it gets distribution from your serum to different organs. That's what how it happens. And Dr. Dharanindra speaks about that if you do a heme adsorption therapy during that period, probably your most of your toxins which are not redistributed into the different system can be pulled out. But there are reports, if you review Dharanindra from Up to Date, they say if you do not have, because the binding, the protein binding part of your paraquat or a diquat is not very high like what you see, because if it is a highly protein bound, you need exchange. It's not possible with any form of your hemoperfusion or a hemodialysis to remove. But it's
Exactly, sir.
plasma binding is not heavy. So they say if you do not have a hemoadsorption hemoperfusion therapy in your unit and you are far away for 4 hours or 6 hours to reach somewhere, your hemodialysis may be a modality where it can have a reasonable excretion. That's what up-to-date literature says. And the reason for that is, again, if you have a diet, as you said, if you have a evident poisoning with your urine test positive, that's a more so reason of doing. And as you pointed out, there are more and more reports. If you combine them together rather than one, there has been some beneficial effect. And you rightly pointed out, if those who has a renal failure, suppose some of them who develop a renal failure, then they need uremic toxins to be removed, acid balance need to be maintained, electrolytes need to be maintained. All these things also been taken care. And there is an interesting question by Dr. K.C. Misra. He talks about, okay, you have done a hemoperfusion after the patient receives. What is the duration you do? For example, you do for a 2-hour cycle or a 4-hour cycle, and you remove it, and you know if the patient got some of the drug got into distributed into the different organs, they will again secrete it back to your blood. So what
Exactly,
will be
sir.
your next cycle? What will be your next frequency of cycle, and what is the duration?
Exactly, sir. So what happens is after your hemoperfusion, we repeat the urine diethionate test at 2-hourly intervals, second hourly intervals. It is very cheap. It doesn't cost much,
Okay.
and we repeat it every 2 hours, sir. And when you get 2 or 3 tests consequently negative, then we do it every 4 hours. So if you're getting after 4-hourly, 8-hourly tests also consistently negative, you don't need to repeat it. But you're getting it positive. Sometimes what happens is the first 2 tests will be negative, but the third test positive ho jayega, redistributing ki wajah se, just like you described. So when it becomes positive, we again start the hemoperfusion again. In toxicology, especially in paraquat, we don't have any comparative trials comparing second hour hemoperfusion, 4 hours hemoperfusion, 3 hours hemoperfusion. We don't have good randomized control trials comparing. So many a times it is the experience with the compound, with your personal experience and expert opinion, it has to go along, sir.
So that's maybe a way to actually keep on monitoring your urine for the toxin, and if it comes back, probably repeating it. And people do repeat every 12th hourly, 24 hourly, who don't do any urine test, but your way or some method which you're using, looking for urine every second hourly and getting it done. Suppose you get after 3 samples, then you repeat it, hemoperfusion. Okay, after that, again, you keep on repeating that. You did a second
If you are getting
after 4 hours.
if you are getting 4-hourly samples, 3 to 4 4-hourly samples negative, then you don't need to do it again.
Okay, if you got positive and you have done, after that again you are keep on repeating it.
After a second hemoperfusion or a third hemoperfusion, we again do the second hourly repeat of urine urine Dithionite test. It is very simple. So we do it again. And after 8 hours of any hemoperfusion, it is first or second or third. After 8 to 14 hours of the last hemoperfusion, the urine sample is negative, then it is very less likely that afterwards it will become positive.
What is the duration of your hemoperfusion?
4 hours, sir. 4 hours.
So, Dr. Gupta, any comments on this? Some interesting points made by Dr. Dharanindra.
Yeah, absolutely fine. I do agree what he's saying. We usually repeat because we don't do testing. So we usually repeat after 20 to 24 hours, and usually 2 or 3, not more than that. Because beyond that, possibly, because it is a by 2 compartment model for the distribution, most of the drug is distributed in the lungs, and that is the reason of the lung fibrosis. So usually we repeat 2 times or maximum 3rd time, not beyond that. And second,
please.
Second thing, that severity, just theoretical probably, because we are not monitoring the concentration. So severity scoring is also there for looking at the severity score, and you can prognosticate those patients. So you are counting the time when you have started the intense therapy, and then you measure the plasma concentration of the paraquat, and you multiply if the score goes beyond 10. Less than 10, then you have a better prognosis as compared to if it is going beyond 10, and it may lead to higher mortality in the group.
As expected, some interesting questions related to the role of cyclophosphamide and methylprednisolone in starting day 5. Dr. Gupta.
People have tried a lot. People have tried dexamethasone, people have tried cyclophosphamide, people have tried antioxidants, but none of them have shown any mortality benefit.
Dr. Dharanindra, comment from you.
Sir, cyclophosphamide, steroids, and all that, it is like the tissue damage has happened. You're trying to tone down the tissue damage, free radical injury, and all. We don't have, we cannot conduct RCTs comparing without or without. So the literature I have gone through, we have found no trials comparing, the not trying and trying. So we give it, sir. We give it in our experience. We give these things. We give
Like what are the
steroid
things you
therapy.
give? What are the things you give?
Sir?
What are the therapies you give along with your hemoperfusion?
We have given dexamethasone, steroid therapy, methylprednisolone. We have given cyclophosphamide. And what we have seen is
all the patients who had hemabsorption, or that's different?
No, sir, not all patients, sir, not all patients. If we see involvement of other organs, signs of other organ failure, if the SOFA score is deteriorating, for example, the renal SOFA, the pulmonary SOFA, the cardiovascular SOFA is deteriorating after the hemoperfusion therapy, he starts requiring oxygen, he start progressively increasing oxygen requirements and all that. If we see that happening, we straight away start. But N-acetylcysteine is one therapy we are starting for all patients. N-acetylcysteine, we started at the door.
So the largest, it varies with individual experiences, and there are many small clinical trials in the literature which suggest there were benefits. But the largest trial as of now in the world has suggested there is no clinical benefit out of this high dose of methylprednisolone or a cyclophosphamide or any combination of these therapies. And the dexamethasone 8 milligrams 8 hourly as an anti-inflammatory dose for the airway edema or whatever way for that low dose has been suggested from up to date, but the other things are personal experiences on the basis of that. Ascorbic acid and N-acetylcysteine as an antioxidant has been used extensively, and many of us at this point of time use N-acetylcysteine like the liver toxicity which we see for all patients. So we do use NAC as a standard of therapy, but the rest all is up to you, and individually it varies from practice to practice. As Dr. Gupta, we don't use the cyclophosphamide or a high dose of methylprednisolone. We stick to 8 milligrams of dexamethasone 8 hourly for maybe a couple of weeks or more if the patient continues to happen. So the other part is there were questions related to what is the cost of hemoperfusion, Dharanindra?
Sir, hemoperfusion cartridges initially starting anywhere between 17,000 per cartridge to 28,000 depending on the company, sir. Usually when we are doing volumes, they come down on the cartridge cost, and we
What is the cost to the patient or MRP? That is your individual, probably you are handling with a cost effective way, but what is the cost to the patient MRP?
Sir, MRP on the cartridge is anywhere between 22,400 like that, sir. Usually what happens is that we may require 3 to 4 cartridges, and initial 24 hours, basic to basic in a tier 3, tier 2 town, anywhere between 17,000 to 70,000 to 1 lakh rupees. They pay with the ICU charges, with the hemoperfusion charges, with the catheter charges, everything.
Duration of NAC therapy.
Duration of NAC therapy we have given for 48 to 72 hours.
Gupta sir, there were questions related to ECMO. You said you had 1 or 2 opportunities to use ECMO. So what is your take there?
I see. As for ECMO is concerned, we were able to maintain oxygenation and patient was absolutely fine, conscious. There was no issues. But the only issue with the ECMO is because whatever the changes has happened in the lung, it is going to be permanent pulmonary fibrosis, and patient will be needing lung transplant. But there are some literature has a difference of opinion, because initial few cases they showed that there is a after lung transplant patient had improved and they had a good life. But the recent 2-3 case reports have shown that if the plasma concentration of the paraquat was high, so the transplanted lung has also got a paraquat and it led to fibrosis. So probably you have to wait for almost 3 months. What they had suggested in those papers, that at least 3 months, so that you can reduce the plasma concentration up to the extent, probably if I don't remember exact figure, but it is less than 4 microgram or something like that. It has to below this before you attempt for the transplant, probably then that can be successful. So it is because ECMO is a costly therapy and you're not certain that when this plasma concentration is going to come down, and moreover when you are getting the lung match that can be transplanted. So a lot of issues are there. In India, at least, I have not heard about any paraquat lung transplant, successful lung transplant. Some maybe it has not been reported or something like that. Because we sent one patient, but it was not converted to the transplant.
So the sequentially, sir, the ECMO has been offered as a bridging thing, as pointed out. When you start getting effect of the lung, we know it can be a irreversible permanent damage. It's not just for a support, but it need to be bridged to something. So it happened to the Yashoda group of hospitals, where in the last month, we received 2 cases. One was transferred from some part of Andhra Pradesh to us, and one were from our own patient. And these 2 patients had a recovery of both kidney. That's another interesting point. Some of our audience question. The renal failure generally will have a recovery over few weeks. Initial few weeks, they will have a renal shutdown requiring hemodialysis. But over a time, slowly the renal system may recover and they may have a recovery. Same thing happened after a month, and liver started settling, but the lung has gone into a reversible fibrotic, depending on an ECMO which has bridged. So these patients, after the same, the urine Dithionite test and the paraquat levels, after a 6 weeks of gap has been transplanted, and these patients were successfully discharged, and touch wood till this point of time, these patients are holding on well. And there is another patient who has recently been transplanted after ECMO bridging. This patient has also been discharged home, but yes, we are waiting for a adequate time to pass on, at least for a couple of months or more, to be one of the first of its kind in India to be published in the world of journal. So that's what we are waiting for. But that will be a separate webinar once these cases complete their tenure of that. But there is an interesting point which actually many of our audience are bringing. These are points related to that if a kidney is involved and then followed by a liver is involved, both of them has a reversibility at some point of time. But if a lung gets involved, what will be the sequelae of it? Is there a scope that there will be a reversibility? Because we talk about if a patient needs an invasive ventilation, other than the case which Dr. Dharanindra mentioned about a combination of cocktail of poisons, but if it is a purely a paraquat poisoning and the patient is hypoxic to an extent that needing invasive mechanical ventilation, or a patient who is acidotic with a high lactate or hypotensive with myocardial injury, what will be the chance? Because at that point of time, aggressively, invasively managing them with all this combination of cocktails versus giving a palliative care. So what is your take on that, Dr. Gupta?
See, there are several issues in this. One part is the clinical issues. The second one is the financial issue, because that is another aspect that you keep giving a intensive care management. Yeah, in India especially, in our setup of the patient. So you keep giving an intensive care management, and you know the outcome that this patient is not going to improve. So I think once we have there is established uh, lung involvement, hepatic and renal, as you rightly said, that there is a fair chance that that can recover. But once the lung involvement is there and patient is getting hypoxemic, then possibly that is the time, because it is very difficult to counsel the family. Most of these patients are young, and you can't explain it to the family because they will ask that 10 doctors, and probably everybody will give the different opinion depending upon his experience and knowledge. So that becomes a very challenging. But yes, we do tell them, and most of the time, in my own experience, all these patients land up with a dump that they take the patient to the home because of financial constraint. But yes, they should be offered palliative care once we know that there's a lung fibrosis, the financial issues crunch are there, and there is no chance of recovery. So possibly these patients can be supported, they at least, and their family should be counseled, talked, so that they are able to cope up with this issue, and they sit with the patient in the last moments when they know that in a few days probably, or in a couple of hours, the patient may not survive beyond that. So definitely yes, once after the intensive therapy we know that this is an irreversible change, so we should go for the palliative care for these patients.
Dharanindra, what is your take? Kidney involved, fair enough. Liver involved, fair enough. Lung getting involved, patient getting hypotensive, acidotic, lactatemic. What is your take? Do you still aggressively manage them, or you give them the family an offer? That comes at a week time. Sometimes, as you said, in a very high dose, it can come at within 24 hours time.
Sir, you're asking me, sir?
Yeah. Your take.
Sir, one thing is there, sir, if this patient is presenting with all signs of organ failure and that you have described, the thing is this, when they come to us, as we discussed, all these patients are young, and it is very difficult to see them suffer and go down the spiraling down pathway. So many of these patients, the most common death happens in paraquat poisoning because of respiratory failure, irreversible respiratory failure, and that is agreed worldwide. And many a times it is very difficult to see them go also. So we try to give whatever therapy, invasive therapy to them. It is very hard for talk about palliation to a young patient's relatives. So we had at many a times we had to offer full spectrum of therapy to them available with us. And if they agreed, if they are affordable enough for extracorporeal therapy also, we would offer them. The big ticket here is affordability, sir. And the demographic group in which this population is coming from is not affordable in the first place. And if they are affordable, definitely we will offer them the extracorporeal tickets, sir, and further bridging to the lung transplant.
Okay, and this actually brings to that interesting part. So you say it's very socially disheartening to offer them a palliative. You do everything whatever is possible as long as they're affordable and they wanted to spend that money. But I just wanted to know, is there any fortunate patient who had a recovery from those stages?
Sir, all the cases that we have seen at Aster, Ramesh, Vijayawada, sir, for whomever lung was involved, they are on the ventilator, and they presented late with multi-organ involvement, 100% mortality.
So this is the message, take-home message. If we are honest to our system, all the patients who actually get a irreversible lung injury, severe hypertension, lactatemic, acidic, in spite of your dialysis, none of them are going to make. It can happen in 24 hours. It can happen in 1 week. This is again an interesting data. If the toxin quantity is very heavy, the rapidity with which these organs get affected can be as short as 1 day. If it is lower and you have done some heme absorption and you have taken out some time, it can slowly happen over 1 week to 10 days. It may look that the patient is relatively stable. The family says he's talking, he's laughing, he's cheerful.
Exactly.
He
Exactly, sir.
maintains oxygen levels are normal. You are saying lung will get involved. Except the dialysis, you will be holding the patient on. But at the time of 5th day, 7th day, you see the saturation dipping from 100 to 98 to 94 to 80. You keep on seeing he gets tachypneic, and you saw the shadows.
Exactly,
This
sir.
is what
I
what
agree.
we see. That's what we see.
Exactly, sir. Exactly. You just described in 3 lines that what I saw in the last 3 years, sir. You know, if they ask me out of danger in Telugu, they'll ask, sir, ఇప్పుడు అవుట్ ఆఫ్ డేంజర్ ఇప్పుడు అవుట్ ఆఫ్ డేంజర్ నేను ఒక్కటే చెప్తాను 14 రోజుల వరకు నేనేం చెప్పను అవుట్ ఆఫ్ డేంజర్ అని. Sir, they will be surprised. Sir, the patient is talking, eating food. Why are you still so cautious about your counseling? Please, I tell them, Ma 14 రోజులు గడవాలి. You know, the same thing happens. You remove the poison, you remove the toxin. The first 2-3 days, you'll have honeymoon time. Oh, my patient has come in time. I removed the hemoperfusion. I've done everything. Especially for the big quantities of injections that I have shown in my cases. One case, exceptionally high amount of toxin, and he came in to us within 4 hours. We thought we did everything right. We hit the sweet spot. We did hemoperfusion, everything. We thought it's going nicely, and urine diethionate came negative. Again, it was coming positive after 14 hours. Again, we did hemoperfusion for almost 3 days. We did 5 or 6 episodes, and immediately that person developed ARDS, multi-organ failure, and succumbed. When the quantity is too high, the damage is already happening, irrespective whether you're doing your hemoperfusion, how much your quantity you're doing, how many frequency, duration, irrespective. If the concentration is high, we cannot salve much. I've
So
seen
that
it in our case.
that is interesting because in third patient of your seat, the patient presented to you within the 4 hours, but the patient died.
Yes, exactly, sir.
And the quantity was high. So that is again a point. Many of our doctors who present to me saying we had a patient of Paraquet who survived. I say it is also depends on the quantity. If the quantity is
Exactly.
very small and diluted, see it is the percentage which we talk about 20 to 24%. That's what is the commonly available commercial preparation, which they say lethal
20%.
dose is somewhere between 20 to 30 ml. But if it is less than that, maybe 5 ml, 10 ml, and in a diluted form, added with some cool drink, added with some water or something else, and the patient is lucky to take a smaller quantity, probably you are much below the lethal dose, and you say, I had a paraquat poisoning patient. I saved the patient by giving methylprednisolone. I saved the patient by giving ascorbic acid and all. So that can be a
Yes,
carry
yes.
away in many. So the patient survived not because of your treatment. Patient survived because he had a very low lethal dose. So that's our take. So I think we had an
In
interesting.
that first case, I'll tell you, sir, interesting thing. You know, you were telling about dilution with alcohol, dilution with cool drinks. This fellow has diluted it with OPP. Give more OPP and less paraquat.
He had a lucky chap. So, sir, there was a repeat question that what will be the ideal time for a lung transplant? You answered that, but I think you can repeat it, sir.
Yeah. It basically there is always a risk of the transplanted lung is again getting fibrosed because of paraquat. So the concentration has to come down, and it has been seen that almost it took 3 months in the 1 or 2 reported cases for the complete removal of the paraquat, nearly complete, so that there is no effect to the transplanted lung. So roughly 3 months time at least.
So that's what is what I mean ideal. And if you have a serum paraquat level, you do a serum paraquat level, you do all the urine routine test, and then probably you take a call. The reason is if it get redistributed and come to the plasma and your transplanted lung gets again exposed, you're taking such a heavy risk with such a financial burden to the family, getting a lung from some donor, and that lung
Yes.
getting affected by paraquat is a very high risk. So you have to weigh all these risk benefit on getting re-exposed. So that's why there is always a buffer given, and you measure the levels and you take out the risk of this new lung getting affected by paraquat exposure, then only that would have been an ideal time. But we need more and more data to see. Knowing that
That's
there
why
is
they say, sir, that is why they say, except for hemoperfusion, delay everything else in Paraquet,
okay.
except for hemoperfusion.
So there is another interesting point which actually Dharanendra mentioned in his talk regarding there is a high volume hemofiltration is which has been talked about. This is the poison where you need a regular kind of, as you said, hemoperfusion, hemoadsorption therapy with charcoal, or a regular dialysis. CRRT is going to take a longer time for the same kind of effect. So
Exactly,
as
no
you
role.
pointed out, CRRT is a big no in this. You need something which will be removed in a shorter time, maybe 2 hours or 4 hours, and that should be effective in this mean, not a. There is another interesting part which we came across. One of our patient, a young guy, middle class family, had a few acres of land. He wanted to do everything. He insisted us to kept on fighting for his patient. Initially had a AKI within no time of 8 hours, as everything was mentioned. He received to us at 8 hour. We tried that hemoperfusion, whatever possible, along with the dialysis, because he had a acute kidney shutdown with acidosis also. But later on, after 4th or 5th day, we started having a liver injury with his oxygenation between 94 to 98. His bilirubin starts climbing with enzymes being somewhere between 5 to 10 times. It bilirubin climbed from 2 to 7 to 15 to 22 to 28. And this 28 happened in no time of 6-7 days, whereas his oxygenation remained around 94 to 98. And at that point of time, he started having encephalopathy with ammonia levels shooting to 200. Then we had a long chat with our gastroenterology team, and we talked about a possibility of a plasma exchange in them to actually treat not a paraquat poisoning, but some component of the acute liver failure or acute hyperammonemia induced encephalopathy. So any comments on that, Dr. Gupta, sir?
Yeah, definitely. For this kind of a patient, plasma exchange will be helpful to manage the acute hepatic failure. We do use plasma exchange in these kind of a patient, not in a paraquat per se, but any patient who is having such a high bilirubin and is having encephalopathy, we if it is on the lower side, say 10 or 12, then we try with the CRRT because that also filters good amount of ammonia and those. But otherwise, we go for the plasma exchange in these patients.
We discussed this component. This is a very interesting point. We discussed with our nephrologist whether a CRRT or a plasma exchange. We had a cost and benefit ratio. We felt if we are doing it only for the bilirubin clearance or an acute liver failure, probably plasma exchange would have been much cheaper than CRRT. They suggested to avoid the unnecessary filter of a CRRT and also the whole fluids which is required. So plasma exchange with an FFP with albumin costed us almost 1/3 of what CRRT do. Then we inclined towards a plasma exchange, and we knew CRRT would have not offered us anything more than this.
True, very true.
What is your take on that? Requiring a plasma exchange in acute liver failure with paraquat, we know this has been a very grading, and the grading is getting better and better nowadays with all those acute liver failure induced poisons like aluminum phosphide, yellow phosphorus, and all that stuff. But in paraquat with a bilirubin of 28, lungs not involved, kidneys shut down on dialysis, but bilirubin is climbing.
Then definitely I'll go for the plasma exchange in this patient because still lungs are not involved, and I'll give a chance so that patient doesn't go in encephalopathy and we are able to handle this acute liver failure.
Yes, sir. I think, sir, even though the plasma exchange maybe it resulted in some lung injury also, it is worth it. It's worth doing it.
So what are the most common comorbidities and post-paraquat survivors other than lung injury, and how should be the mode to follow up them? Both of you, any comment, Dharanendra? How many of you followed up?
Yes, sir. We have followed quite a bit of young people, sir, especially the first 3 to 4 cases. At the discharge time, for example, on the 8th day or the 10th day, if they were able to do, functionally their regular activities, if they're not having any residual organ function at the discharge, these patients continue to do well, except for post-traumatic stress disorder and all those things, which they took the poison in the first place. For example, that young boy, what you mentioned, 16-year-old fellow, he kept coming back for counseling and all that. His grandparents are in contact with us, except for when they're discharged with no organ failures, usually they tend to do well.
Yeah. The only thing we do the same thing for any poisoning patients who has used it for self-harm. We always initiate counseling as early as possible whenever a patient is in the condition, and we always ask them to continue with the counseling or antidepressants, whatever, because most of these patients are already on the antidepressant or some other issues. So we always ask them, because there is a good chance of reattempting these things, because in aluminum phosphide, even I have good data for 10-11 years, and two of our patients actually attempted again the suicide. So we are very particular that they are following up for this the psychologist, and they are on the
Psychiatric
antidepressant.
follow-up and psychiatric counseling must for them, because all your efforts, all the family efforts will be vain if they reattempt the same thing. So we had a similar kind of experience. Many of these patients who didn't land up in lung injury, had a kidney shutdown, needed a dialysis, recovered in few weeks time to a normal renal functions, and our follow-up was also equally same, that they had a normal renal function as long as we followed. And as liver also, initially those who had a liver dearrangement settled down in the hospital stay, continue to be healthy. We didn't had any problem. Yes, those who had a lung fibrosis and mediastinitis and mediastinal leak and all that, most of them didn't survive without any bridging. Only we had 2 cases. I think we had a lot of enthusiasm, many questions, almost a few dozens of questions. There are more than a couple of hundred people who joined. We always see 5 to 6,000 people viewing these programs over the next couple of days or so. So this is always a learning experience for us from all of you. I thank Dr. Vivek Gupta, who agreed to be a part of it with his vast experience. Sir, it will be a glad for us if we bring your all experience of aluminum phosphide and other poisons to the limelight, so that these videos will be online available to all those guys who can actually view. From Paraquet we will move to the other poisons in the later part, but we thank you from the bottom of the heart for your presence and sharing your wisdom. So thank you very much.
Thank you very much for giving me opportunity to join this. Thank you.
Yeah, and thank you, Dharaninindra. It has been a phenomenal talk from you. When you share your experience, this is a different platform than regularly. When you talk about your data, when you talk about your patients, when you talk about your recoveries, your deaths, then it looks more authority than it is just talking from a theoretical background. So we thank you, Dharanindra, for bringing these cases, bringing your data, bringing your all experience, and we wish you all the best. We hope to get more and more literatures published from your institution, and probably all of you can be a part of the same contribution. And thank you for bringing these all things to us and making this session more interesting. Thank you, Dharanindra.
Thank you so much, sir. Thank you so much for the invitation, sir.
So I thank all the participants for being with us and making this topic interesting. We had more than 40 questions lined up there. So we tried to actually answer as many as possible. But because of limitation of time, we conclude the session. Thank you for being a part of it. I conclude the session. Thank you.
Thank you. Good night.
Yes.